So certainly things have improved, but I really think that we can still do better. So what could we practically focus on to make things better, have fewer deaths? So things to focus on: identifying the at-risk animals, and we've already done that. If you're old or you're very small, you need some extra attention. We should be pre-medicating our animals. We should be providing good perioperative analgesia to have good recoveries. Rethink intubation of cats and judicious fluid therapy. Those we've covered. So the things I want to focus on now are improved monitoring and how important it is to keep these animals warm, how to avoid or prevent hypothermia. So monitoring is something that we ought to do. Definitely prevention is always better than treatment. And we know that having a person dedicated to anesthesia does decrease the risk of death. That's not always possible. So what kind of monitors should we use in a busy situation? So what they showed in these different practices in the United Kingdom, what were people using? Well, about 50% of people had a pulse oximeter. But having a pulse oximeter and using a pulse oximeter is not the same. And things like if you want AHA accredited, you have to own one. It doesn't say you have to use it. That's a little loophole there. About 12% of people were using capnograph, very few people using EKGs, and not many people actually routinely monitoring blood pressure. But it's pretty clear from the human data that if you use pulse oximetry and capnography, it's going to detect 93% of critical incidents related to anesthesia. We are probably not going to be moving into this arena very quickly, but pulse oximetry is something people are, using a lot, and the technology is getting better and is less expensive. So if you have a critical incident, and certainly there's been a lot of studies like what do people respond to? And we can buy anesthetic monitors that are visual or audible. And it's pretty clear that people respond to an audible alarm or a change in what they're hearing versus what they might not be seeing. Because we are not in a busy clinic staring at the monitor. We should be looking at the animal, or we're doing something else. We're teching the case or something. So you should be focusing on getting monitors that have audible outputs. So, pulse oximeter. That would make you jump. Oops. So people really respond, and if you're the surgeon who's also doing your surgery but wanting to know what's going on, the audible alarms. The other thing is the reason that the manufacturers put in what are called doctor-proof alarms and buttons, and this for a reason. So you should not be turning off or silencing the alarms. So this is, and I understand, this is luxury, and this is what we're dealing with a lot of the time. We have people kind of rotating, but again, if you have something audible and someone that's at least scanning the room, we can probably do a much better job picking up problems quickly. So pulse and heart rate, things that we should be looking at, is the heart rate really high? And then again, how high is too high, and what's the definition of bradycardia? So certainly tachycardia, if you routinely use anticholinergics, atropine or glycopartate in your protocols, you're going to see a lot of tachycardia, and it's not a good thing. I do not use atropine or glycopartate routinely. I only use those two drugs if I need to treat a slow heart rate. It could be a fast heart rate due to pain, or the animal's too light for what you're doing. And then bradycardia, again, a lot of the students tell me that they've been told that a heart rate of less than 60 is bradycardic, and I'm like, well, what if it's a really fit greyhound? I mean, it never has a heart rate of 60. And if it's a Chihuahua, then 60 is pretty low. So it's in comparison to what their normal heart rate is. But certainly you'll see bradycardia, vagal tone, potent opioids. But one of the commonest causes of slow heart rates is hypothermia. And if you think about it, cardiac output, we always want that to be good. And it's a combination of heart rate and stroke volume. So changes in heart rate are going to have a big impact on cardiac output. Obviously, if one or the other is zero, then output is zero. And then blood pressure, we do, for very short procedures in healthy animals, maybe we don't need to do this. A lot of people tell me, I can feel the pulse and tell you if it's okay. Now, I've been doing anesthesia for a long time, and I cannot put my finger on animals. I can tell you it's got a pulse. But people, have to think what you're feeling when you feel the pulse is the pulse pressure, the difference between systolic and diastolic. So in this, and if you actually work out how the mean pressure is calculated, and it's the mean pressure that dictates perfusion. So this animal is going to feel like it's got a fantastic pulse, but its mean pressure is only 60. This animal, pulse pressure is much lower, but by the time you do all this math, this animal has a much better mean arterial blood pressure. So touching the pulse tells you it's got a pulse or not. It doesn't tell you necessarily how good it is. So blood pressure, what's okay? Well, what we would like are mean arterial pressures of over 60 or systolic pressure over 90. Those are kind of guidelines because that's what we know will cause good organ perfusion. And why worry? Well, our older animals are higher risk anesthetic candidates, right? And what could go wrong? All sorts of things could go wrong. But certainly, I think one of our main concerns in the older animals is if they have low blood pressure, we're going to have renal hyperperfusion. And a lot of these animals do have limited renal reserves. And we need to be careful that we're not causing any more insult to their kidneys. So hypotension, how common is hypotension? And again, a lot of people will tell you, we don't have any problems with hypotension. We feel the pulse, there's never a problem. But again, if you're not measuring it, so the group at Colorado, what they did, they went out into local practices and just took a Doppler and went out there, looked at elective procedures in healthy animals, cats and dogs, and looked at how common it is to have a hypotensive event. And in cats, between 10 and 33% of the time, and in dogs, 8 to 32% of the time. So hypotension is common in our patients. So we can do indirect blood pressure monitoring, and that's routinely what we're going to do. If you have a person that can manually do the Doppler, it's a very nice technique because you have the audible pulse signal all the time and then intermittent monitoring. You can have automated machines, which are all well and good. They're usually set to go off at a specific time and so on, a lot more expensive than a Doppler. The thing that is very important if you are going to invest in blood pressure monitoring is that you do it right, because if you don't do it right, you get lots of, inaccurate readings. The most important thing is choosing the right size of cuff. And so the cuff, when you lay it this way, endwise, should go 40% of the circumference of the limb that you're going to wrap it around. So it should go from here to there. And then when you put it on, this is a cat, obviously, put it on, that's going to give you an accurate reading. If it's too small, it overreads, and if it's too big, it underreads. So this is an important thing. So you do need a range of cuffs to work with. And then my preferred technique really is, I really do like the Doppler, because we can put it on, we can listen to it, and then with a sphygmomanometer, we can get some intermittent monitoring. Now, if we're doing a 5-minute castration, I'm not going to do this. If we're doing a 30-minute, 45-minute procedure, I'll do it. Or if I have an older cat that I'm worried about, I'm going to do it as well. The other thing is you have to think about what are we measuring and what's it telling us. So if we remember back to our good basic physiology, cardiac output is going to be altered by heart rate or stroke volume. That's pretty obvious. But what we're not measuring cardiac output. We're measuring blood pressure. And blood pressure is dependent on cardiac output and systemic vascular resistance. And so, you can measure blood pressure and say, oh, everything must be good, but not necessarily so. So what situation would we have a very high systemic vascular resistance? That would be when we use a lot of alpha-2s in our animals. We get vasoconstriction. So a lot of the time, the animals will have a very good blood pressure because we've just manipulated this, right? This may not actually be very good. So you can be misled sometimes that you have good blood pressure, but perfusion might not be ideal. So it just gives you a good idea, but you have to be thinking, like, why is the blood pressure really good? Is it because of drugs, or is it because it really is good? And just think about what you're measuring. So risk factors, this data we've already shared. So pulse monitoring and pulse oximetry makes anesthesia safer for cats, without a doubt. Decreased it by down to 0.2, so almost a 5-fold decrease in mortality if you are just doing something about monitoring the pulse. So pulse oximeters, they're becoming less and less expensive. They give you an audible sound. They're measuring hemoglobin saturation. You can listen and know how fast the pulse is. And just by how they change the loudness, you get a qualitative indication of the pulse strength. When they get very quiet, we sometimes pay attention. So they do serve a very good role. Are they always reliable? The answer to that is no. So there are some patient problems. Abnormal hemoglobins, that's not very common. Patient movement, that is a big issue, especially if you're trying to do a pulse ox on an animal that's waking up and shivering. And then one of the biggest things that we don't think about are extrinsic problems. And one of them is the ambient light, and that interfering with the little red light. So lighting, the lighting that comes from surgical lights and from fluorescent lights can interfere with the pulse oximeter reading very, very markedly. So my advice is that you should cover the probe, especially if you're working under OR lights or under fluorescent lighting, either cover it over. The other thing I sometimes do is wrap the tongue in a wet gauze and then put my pulse oximeter and then cover this. But if you actually hold your pulse oximeter up to a surgery light, you can sometimes get it to give you a reading because it's interfered with the little infrared beam. So cover it up. Evaluation of pulse oximeters. This is a fairly old paper, but has been very useful for me in how I use my pulse oximeters. So they took 5 commercially available pulse oximeters and evaluated them in the dog, the cat, and the horse that we're not talking about. They looked at different sites. They looked at the tongue, the paw, the ear, the lip, and the prepuce or vulva. You know, places that we all have like, oh, can I get it to work here? Can I get it to work there? You know that. And then what they did was these were experimental animals. They had a wide range of saturation, well oxygenated and not well oxygenated, and they looked at accuracy and how many failed readings. And the main thing that came out of this study is how to position or where to put the pulse oximeter. I'm guessing that nearly everybody here sticks it on the tongue. That's what people tend to do. So is that the right thing to do or not? Well, depends if you're a dog or a cat. So we look at the dog data, and I've actually, found this to be true. So in the dog, the toe, actually, between the toes or in the web, was better than the tongue, but the toe or the tongue are quite good in the dog. The prepuce and vulva are good, and then the worst place in the dog was the lip, and then the very worst place was sticking it on the ear. Not accurate at all. Now, when it came to the cat, what they actually found was that the paw was better than the ear, better than the front paw, better than the tongue, better than the lip. So actually, the paw, the rear paw in the cat, is the best place to place your pulse oximeter probe, and that's what we try and do as much as possible. And as you'll see, the tongue, actually in the cat, is not a great place to put it, but it's okay in the dog. So that might, if you go back and kind of fiddle with your pulse oximeter, you might get some better luck. So what they don't tell you, certainly if you have an animal that's intubated and breathing 100% oxygen, your pulse oximeter will be beeping away and telling you that they're great, they're 98% saturated, everything's good. Don't forget, they're not telling you if they're hypoventilating. You can have an animal, and this is a real blood gas from an animal with a pulse oximeter reading of 98%. You all know this is not good. So the animal was severely hypoventilating, got a very high CO2. So if they're breathing oxygen, your pulse oximeter isn't going to tell you that. Breathing room air and hypoventilating is going to alarm, and they're going to get desaturated. So it doesn't tell you everything, but they are still worth using. So then I'm going to focus a little bit on hypothermia, the big chill. And I think it's something that you can really go away and focus on, and it'll make a big difference in mortality and how well your animals come out of procedures. So perioperative hypothermia, why does it happen? What's bad about it? And what can we do about it? That's kind of it in a nutshell. So normal body temperature is absolutely essential for enzymatic function, nerve conduction, muscle contraction, blood flow, and clotting of blood. So all very basic normal body functions are all totally, in mammals, temperature dependent. And if we look at the circuit for thermoregulation, most mammals, when they're conscious, regulate their body temperature in a very, very narrow range. It doesn't fluctuate much between plus or minus 0.2 degrees Celsius. And that's because we have thermoreceptors, an integrated central nervous system. We have the environment, heat loss, heat production, and metabolism. This is a very, very tightly controlled circuit in mammals. And if you think about anesthesia and surgery, what we do, we disrupt this everywhere. We give drugs that alter the central nervous system function. We decrease their metabolism. We certainly stress them in cold operating rooms. So we do a lot to disrupt this whole tight mechanism. So certainly animals are going to lose heat through radiation. They're all warmer than the ambient temperature, well, in most places. So the animals are going to radiate heat to the colder ambient temperature. Then, how often do you see an animal sitting on a cold surface? Quite often. They're going to conduct heat straight into this cold metal table. It always seems to me that I'm standing right below one of those air vents, and so we get wind chill by putting ourselves underneath an air vent, so we have convection losses. And then we challenge our animals with evaporative heat loss from using cold prep solutions that suck heat out of them. And then obviously, if you have exposed viscera, obviously the moisture is evaporating and taking heat with it. So we expose them to a lot of challenges under anesthesia and surgery. So a long, long time ago, people were really, knew that animals got cold under anesthesia. This is data from back in the 70s. So we've known about this for a long time, but it's not until more recently we've had good techniques to prevent this. So, and it's definitely a problem with the smaller animals. If you do nothing for 60 to 120 minute procedures in dogs that weigh less than 10 kilos, they can really lose body heat. I mean, we don't hopefully see this very often, but it happens if you do nothing about it. If they're bigger animals, the heat loss is obviously a lot less. And again, what did we say? Small animals are at risk of dying, and a lot of it is probably to do with hypothermia, I think. So anesthesia and thermoregulation. When we anesthetize an animal, we completely withdraw all of their opportunities to behaviorally respond to a heat challenge. They can't shiver, they can't go get warm, because we're laying them there in a cold operating room, all exposed. When we give anesthetics, we reduce their metabolic rate, so they're not generating metabolic heat. And then we give them drugs that alter their CNS, so their hypothalamus isn't working normally either. They can't shiver under anesthesia, and vasoconstriction is a very, very late response to hypothermia under anesthesia. And then the anesthetic agents that we use, especially the inhalants, isoflurane and sevoflurane, cause vasodilation and then enhanced heat loss. So intraoperative hypothermia, the redistribution is very, very sudden, right in the first 15 to 30 minutes after we induce anesthesia. And then the rate of heat loss kind of, is less. And then eventually after, we're not doing routine procedures out here, eventually it's sort of like they begin to vasoconstrict and respond, and we get, decrease. So it's critical, even in, you say, well, I'm doing a really short procedure, but in a short 30-minute procedure, boom, they can drop their temperature very, very quickly. So heat loss begins immediately after pre-medication, because the pre-med drugs alter hypothalamic function, and things like ACE, which I still think are good to use, cause some vasodilation. But the greatest rate of heat loss is the first 20 minutes after induction. Usually they're out in the prep room. You may not be doing a lot to keep them warm. You're using cold alcohol, blah, blah, blah. So that is, even if it's a short procedure, that's when they lose a lot of heat. The complications of getting cold are greatly underestimated. There is almost nothing good about being cold. So one of the big things, and we have data to support that, is how long it takes them to recover. So here's data that was published from an Australian group, and what they showed was if you're in this temperature range, obviously they're using Celsius, so I translated it for you. This is how long it took dogs to roll up into sternal versus if we keep them warm, boom, they're sitting up, they're good to go. So it delays recovery, and that's, everybody knows that. So when they're cold, they have decreased metabolism. Your anesthetic requirements when you're cold are less. And if you just think about physics, if you're still really interested in physics, inhalant anesthetics are more soluble in cold blood than they are in warm blood. So you get a lot more, there's a lot more inhalant on board in the cold animals. The other thing that you will probably now all think about, you'll see it, an animal's coming out of surgery and it just doesn't want to start breathing on its own. That happens quite a lot, right? Well, if you're cold, there's reduced respiratory drive, and there's delayed return of spontaneous ventilation. So you're often sitting there with the animal, and you just keep on trying to disconnect it from the machine, but it won't breathe. It's probably because it's cold. And it's because it's cold and probably still got too much anesthetic on board. Post-operative shivering is something that we try and avoid as much as possible. When you're shivering, you know it's a fairly violent, a lot of energy. So it actually increases oxygen requirement or oxygen consumption by 200%. So you remember, you have your animal on 100% oxygen for the procedure, then you take it to recovery, it's shivering, and now it's on room air. That's 21% oxygen. So you can run into hypoxia, they become acidotic. The other thing is shivering is painful. Shivering itself, you know that when you're shivering violently, it hurts. But can you imagine shivering when you have an incision in your belly as well? So shivering can cause pain as well. Cardiac complications, when an animal gets cold and his heart gets cold, we get bradycardia, decreased cardiac output. And I can tell you, when animals get cold, everyone says, well, it's bradycardic, let's give it atropine. Atropine doesn't work when they're cold. The only solution to bradycardia caused by hypothermia is getting them warmed up again. And then if they get cold enough, the heart stops spontaneously. How do you think they get hearts to stop for cardiac bypass? They dump ice water on the heart and it stops. So bradycardia and decreased response to anticholinergics. The other thing is when animals are cold, they begin to release catecholamines, which makes the heart way more irritable. So that's another problem that we have. The other thing is, think about it. Blood is thicker when it's cold. Just, it's a good pictorial. Think about maple syrup sitting out in Florida, on a picnic table versus in the fridge. Glug, glug, or flowing nicely. Blood's the same. When it gets cold, it's like sludge. And so you have impaired perfusion and increased blood viscosity when they're cold. Blood loss, animals that are cold, and this is from human data, but it can be documented in research animals. In humans, with a core temperature decrease of only 3 Fahrenheit, 1.6 Celsius, blood loss is increased by 30%. So when an animal gets cold, it bleeds more. So that in itself is a complication. I'm going to tell you why. So when when blood gets cold, there's impaired platelet function. Now there's no change in the number of platelets, but there's reduced release of thromboxane, which is what contributes to the whole clotting mechanism. Clotting factor enzymes don't work outside a very narrow mammalian body temperature. And of course, we get animals back to surgery. They've been down to CT, they've been here, they've been there. We get them in the surgery room, and the surgeon says to me, this animal is bleeding. It's like really bleeding. And I'm like, because it's cold. They say, no, there's got to be something wrong with the animal. So of course you say, fine, so you take a blood sample and you run downstairs and you run a PT and PTT, and they're all normal. Because what temperature do you run those tests at? Normal at 37 Celsius. But the animal's bleeding because it's cold. The other thing is fibrillary activity is altered by hypothermia, and you get impaired clot formation. So blood just doesn't act like blood when it's cold, doesn't do what it's supposed to do. Another thing about getting cold is it increases the risk of post-op wound infection. The two things that lead to wound infections is long surgeries and hypothermia. And that's well documented in the human literature, and one study from Pennsylvania documented that in dogs. Why is that? Well, what happens is eventually, a lot of these dogs end up vasoconstricted or vasoconstricted during recovery. You have a decrease in blood flow and oxygen delivery to the wound site. People say, well, if we give antibiotics, everything will be fine. Well, if you have vasoconstriction and poor, blood flow to the wound, and you have that viscous, thick blood and not an impaired perfusion, then your antibiotics are not getting delivered to the wound, and it allows bacterial fixation. And also, hypothermia impairs immune cells and normal immune function. So, you get in the picture, there's nothing good about being cold. So ambient temperature, yeah, here's what you were asking. So the ideal for the patient is 26 to 28 Celsius, so 79 to 83 Fahrenheit. I took this into our hospital and went around the room. Our prep area is at 70. I think it's too cold. We should have it warmer. But our ORs, that's how cold our ORs are. So obviously not ideal for the patient, but it is nice not to have the surgeons falling over. So what can we do about that? We have to do something about keeping them warm. So cutaneous warming, we can Passively, we can put blankets on our animals, and certainly that reduces heat losses by up to 30% by trapping a layer of air, and we can start that, right after we pre-med them. But we can do things active. Circulating hot water blankets, the warm forced air, and then we have this new, some of you may have seen the new hot dog blankets. Certainly these are things that we can think of. But I think pre-warming is important because heat loss starts the minute you pre-med your animal. You alter their hypothalamic function, you might be vasodilating them. So what we do now is when animals have been sedated, but they're waiting to have their catheters put in and so on, they either get a blanket put on, we have a nurse that makes all these little blankets for us, very cute, or we stick them in a cage, either with a warm blanket underneath or with a bear hugger around them while they're waiting, because you can pre-warm or at least prevent that initial drop. Simple things, warm up the prep solution. Even for doing IV catheters, I warm up the prep solution, or just don't use alcohol anymore. Just use saline and warm prep solutions. Blankets during the prep time, you can have your blanket on, if you're prepping something that's not under here, we're waiting, put on a blanket. We often will have our dog sitting up. This is the new hot dogs that we're looking at. It's a nice technology. They're sitting there, waiting for their catheter, but they're still being kept warm, and they were in here being kept nice and warm while they're waiting. But you can use simple stuff. I love bubble packing. If you can make sure people don't pop it, but I save every piece of bubble wrapping I ever see, and I take it down to all the different places in the hospital and say, put this around it if you don't have, something else. Bubble packing is very, very insulating. It's simple and cheap. Other things, a newspaper on a metal table is a good insulator. It really is. Other things I've made is take, these chips, these polystyrene chips that come in everything. I put them into plastic bags, and then seal them. And you can sit a little kitten or a dog on there. They feel warm. If you put your hand on a polystyrene cup or a polystyrene lid, it feels warm. And so I save all of these. I go around the hallways at the hospital picking up all the packing chips and these and using them to try and keep my animals warm. This you can wash. These, if you seal this bag, you can wash those and use them the next day. Again, these things that you see a lot, those things, it holds a kitten perfectly. If you take two of those, a kitten fits in that perfectly. Here's a kitten on bubble packing if you don't have the luxury of heating blankets for everything. Now here's something I would have you stop doing. The warmies. I am going to I keep throwing them away and they keep coming back. These are not a good idea. We know that they're very ineffective, and we have good data to support that. They cover a small surface area. They're actually dangerous. You can cause thermal injury, and the local tissue reaches the temperature of the water. So if you stuff them around an animal, and then the bags get cold, then it's the opposite. The animal, it sucks heat out of the animal. I would like you not to be using these warmy bags. Circulating water blankets are very, very good. There's data out there showing that if we use these blankets, and they looked at a single blanket over the animal, a sandwich of blankets over and under, or actually using these blankets wrapped around their feet and legs, they show that they're very good. But what we learned from that study is if you keep the legs and feet warm, that's a very good thing to focus on. So then you can start thinking about getting, a pack of 20 tube socks from Walmart. It's pretty cheap. And stick them on dogs and kittens' legs, or wrap up, with tube gauze. Keep their legs and feet warm is certainly helpful. Forced warm air, we have data, is definitely, I've been doing anesthesia for 30 years, and I would say that the forced warm air technology is probably the best anesthetic invention I've seen in 30 years. It's made a huge difference in my ability to keep animals warm and have a better recovery. So certainly in cats that weighed under 4.5 kilos, 90 minutes of anesthesia, they had either just passive versus the bear hugger type technology, and there was a big difference in body temperature after surgery. 1 degree Celsius or 1.8 Fahrenheit is a big difference. So very, very beneficial. And we use these certainly in recovery. We don't have one for every animal. This is kind of our communal recovery area over in shelter. Here we are. They're all sharing the blanket that we have for them. But definitely, if you go under there with them, it feels really good. And then this is something that you might be seeing. The engineer that designed or developed the bear hugger has now started this company and is using this special technology. Everyone thinks it's hot dog, must be for the veterinary market. This is actually human product, but they do have veterinary blankets. And it's we don't know what's in it. It's a secret radiant fabric, but it doesn't burn animals, and it's very, very effective. And we are, like I say, we are using the hot dog out in the prep room and again in the surgery room as well. Radiant heaters, again, you have to be extremely careful, and I would prefer you not to use these. So we used to use them. This is a really old picture from University of Florida. We used to have these heat lamps while we were getting animals prepped for surgery. If you get them too close, you can cause all sorts of problems and burns, as that's what can happen. So that was a dog that had a beautiful fracture repair, but was, either an electric blanket, which you can get, can cause burns like that, or infrared lamps. Because if they're laying on an electric blanket, or skin pressure is an issue. I mean, electric blankets should not be anywhere near an anesthetized animal. But these infrared lamps, if the animal's vasoconstricted or it's all being clipped up and shaved, you can burn them. The other thing you should realize is if you use iodine prep solution, it actually absorbs heat. So you've got to be very careful. And we just don't use them anymore. So in summary, I think if you only focus on one thing when you go back to your clinic, and it's hypothermia, you can make your animals more comfortable. I think there's no doubt hypothermia contributes to mortality in our very small patients. So it's very common. There's nothing good about it. Cooling begins at pre-medication, so think about things you can do. Blankets, jacket, whatever. Getting them up off the metal cages. Keep your anesthesia and surgery times to a minimum. We know that's good for mortality. They're less likely to get as cold. And then the warm air systems and the hot dogs are very, very effective, but there are other very simple things, the packing chips and all those things that you can do that will help. So we know how to keep them comfortable, and now we know how to keep them alive. So hopefully there's some tips there that you can take home.